Next, one of the most smart administrator in the country, Dr. Parag Rindani, who is a microbiologist and an administrator by training. But he's the vice president and head of the institution that is the New Age Wokhard Hospital. Parag, I have always been a great admirer of your talk whenever you have given a talk regarding the issue of technology and how to build smart hospitals. But today, I'm trying to talk to you, in fact, to address those people who have probably been not able to start this journey of digitization. So what will be your kind of guidance to them? How should they produce? How should they learn about their own, you can say, maturity level? Unlike, let's say, unlike the HIMSS maturity level, which Apollo has reached number 6 in some of the institutions. But I'm saying that for vast majority of our people, that may not be so easy to follow. So over to you, Dr. Parag Rindani.
Thank you very much, Dr. Agarwal. Really appreciate the invitation. It's very difficult to speak in the trail of two stalwarts, one clinician and one information technology guru. But nonetheless, I will try and see if I can share some light. Okay, so essentially, while we did speak about not referring to HIMSS, we are going to refer to HIMSS because the entire presentation is based about where one currently is located around the HIMSS network. I think it's very important before I start to understand that why do people go to a computer or why do people computerize/digitize? For the last 2 decades, and Wokhard started its journey way back in 2000 and in the year 2000, and that was when we started working with Wipro, which then subsequently faded away from hospital information systems. I think it's very important to distinguish the use of a computer being different from that of a typewriter. Yes, we have learned in computer science when we studied it in school, input device, output device. But what's very important is today the engine has changed. The engine that actually processes information has changed. There are tools available. There are a lot of things available that can help you not only change the way the patient breathes, the way the patient lives, the way the patient's, as my colleague said, HbA1c going up or down, sugars fluctuating, cholesterol fluctuating. But it's very important that it can also be used as a very, very keen driver if you are able to mine the business intelligence that it is able to give you. So I'm going to play the role of the CEO here. And while we heard Dr. Sudhir, our esteemed clinician, and we heard Arvind, who's our IT guru and who's done so much work and reached HIMSS level 6, I'll just talk to you about what is HIMSS, what are the levels, and you probably, each one of our participants who's listening in should probably try and evaluate where you currently are. Because we can only go somewhere when we know where we want to get to, As I always talk about Alice in Wonderland, it's very important to have a strategy where we want to go. So let's just quickly take this from there. So if I want to start with the HIMSS MRAM, which is the electronic medical record maturity models. Now, each hospital will define their own goals very, very specifically. If you're a small nursing home, you might decide, I don't want to have anything. I just want to have a printer where the outsourced laboratory or the outsourced radiology person will print their reports. If you are a complex chain of hospitals, you would then be looking at clinical research models and how are you going to get every patient identified so that it feeds into your clinical research, so that it is able to feed into your research paper publication. You're also going to look at, as I said, business mining, data mining from a business perspective. You're going to look at various ways and means of enhancing medical as well as nursing education. You're going to look at ways of enhancing public relations, identifying case through search engine optimization. You're going to look at ways at being able to auto-publish certain things online based on data mining again. So it's as they say in English, it's the framework of MRAM is from pin to piano. So let's start with the smallest thing. Basically, stage 0, it describes hospitals where even your core clinical support units, your pharmacy, laboratory, radiology, and all these processes are not included in digital environment. Now, I'm going to give India a little small secret, and I think Arvind will agree with me. The first processes that get automated in any hospital are the processes which involve any sort of billing. जहां पे लक्ष्मी जी का आगमन आने की आवश्यकता है, उस प्रोसेस को पहले ऑटोमेट किया जाता है. This is a fact because pharmacy is a place where there is a sale of medication. There's a requirement to maintain inventory. Arvind, thank you very much. The second and the third, laboratory and radiology, are places where if you don't give an output, you will not receive the money. Hence, there is a process to raise a requisition, to take the money from the patient, and then to process the test and give an output called a report. The second caveat, and I will call this Parag's caveat, is no place where a digital output is not required is amenable to automation easily. Classic example, doctors and nurses' notes. Because they are not required to be digitized from a patient output perspective, the digitization of the clinical notes invariably goes for a backseat. Now, let us assume that, as Dr. Agarwal said, that there are certain hospitals who are at stage 0. How do we move them to stage 1? We'll take it one step at a time. First of all, you need to get some sort of good laboratory information system, radiology information system, and pharmacy information system, and try and get it from the same vendor so that they can be integrated. What are the advantages of getting it from one vendor? One, that your after-sales service will be good. 2, you'll be able to negotiate on cost. And 3, and most important, if that vendor is good, you will be able to upscale from these 3 modules into more modules. Like, for example, you will be able to go into medical records, you'll be able to go into biomedical maintenance, you'll be able to go into project maintenance, you'll be able to move into clinical decision support systems. So it's very important that we choose vendor wisely. I think there is a whole monograph by McKinsey on choice of vendor. I'm not going to therefore elaborate on that, but it's available online. My request is to kindly look it up. Now, remember that without the appropriate tools, nobody can function appropriately. So if you are going to expect 25 pharmacists to sell medications in your large hospital and cater to your 5,000 OPD patients from 2 computers or 3 computers, all CEOs, I request you, kindly go back to the board and speak to your CIOs. CIOs are supposed to be your right hand in business. A chief information officer can get you more money than anything or any particular surgeon or physician can. So very, very important to take into conference your CIO, invest in capital expenditure. If you are not able to invest in capital expenditure, you will have garbage in, garbage out. So remember, intelligent investment in the right computers, which will have long-standing effect on your profitability, is something which you must do. We're talking, I think, Dr. Agarwal, about people who don't have any sort of HIS. The second stage will lead to, at some stage, all this clinical data repository will be available to the physicians at a system which is viewable by the physicians, which means that the physician needs to have access to this data either at the patient bedside by way of what is called at Wockhardt Hospital a workstation on wheels, or a WOW, or some places it's called a COW, which is a computer on wheels. I don't like that term. So, or it is viewable if you have given access to your physicians on what is called BYOD, bring your own device. You have restrictions in terms of, security restrictions, but essentially your physicians are able to see that data on their own devices. This system also at stage 2 will send data to your archival system and receive feedback. Okay. Stage 3, you will be documenting all the nursing care, your electronic medical record, your flow sheets, electronic medication management records, and all of this is integrated. At some stage, this will lead to stage 4, wherein you start working with clinical decision support. I will show you examples of these. All of these right now will appear to be extremely hollow words. Now, you can move to this only when you make a fair amount of financial support within your hospital in terms of profitability, because these systems are expensive. Currently, or rather, I think between Apollo and us, we are still fighting with each other in terms of who started using the ISA of Philips first. But currently, there are at least 20 hospitals in the country who are using the Philips ISA, or the ICA, that is the Integrated Clinical System, which is really, really good. And it makes a lot of sense to use that. You're also having options here to take pictures of, for example, a bed sore which the patient may have come in with. You have pictures of a SLE wound, or sorry, an SLE lesion that you may have seen. For example, if you have a patient who's come in and on day 1 there is a toe which is gangrenous, you have an option to take this picture and link it up. You can also link this to the outpatient records. So you may be tracking a diabetic foot ulcer before it started and all the way through it started, and you can also prove it in a legal environment if required. You're also able to transfer images from here. Of course, this all requires a fantastic PACS system. You require very good information technology system in terms of your data transfer acceptability. For example, your Wi-Fi or your data transfer through LAN, etc. You also at this stage introduce your CPOE, and that is the computerized physician order entry. Ladies and gentlemen, a computerized physician order entry is something that is raised by the physician directly onto the computer, thereby minimizing the errors that happen, the transcription errors and all the errors that we normally talk about when we report into NABH on every quarterly basis. That is something that is part of stage 4. What is very important is in stage 4, you're supposed to roll out your second stage of CDSS. That is, you're moving now towards artificial intelligence, slowly but surely. Stage 5, you have images in your PACS. I mean, this is way, way, way beyond stage 0 and stage 1, but you are also able to amend these images. You are able to work with these images, okay? Stage 6, you have a full-fledged physician documentation system in at least one place. This is the HIMSS, this thing. And you have a closed-loop medication management system, which means that there is no human being touching the system, or you have no human being which is recognizing a particular medication. Everything is recognized by the information technology system which is in place, which is where I believe Arvind and his hospital group are. Stage 7. Now, please note, I have specifically put in red. I don't know whether this is possible in India, but I guess everything is possible in India. A hospital at this stage never uses paper documents while providing services. Everything is electronic. I think this is the utopia of every information technology guru. Okay. Now, what we're going to talk about is the way we will move about it. Sorry. Now, there are Arvind and Dr. Sudhir also showed you multiple things. There are various things that can be done, starting from registration, admission, billing, you know, all of this can be taken, feedback, smart medication administration systems. We, for example, have put in a system where we get an auto alert based on if there is a drug-drug interaction, okay? We've integrated the CDSs, we've integrated the SIMS software. All of us remember this book by Gulati and Gulati, which was the Central Index of Medical Specialties. Now there is a software available, and it's possible to integrate the intelligence of the SIMS with your clinical decision support system along with the medication administration. That is the entire system. What happens in this case is that every drug therefore needs to have a barcode. Your medication artificial intelligence, which is your SIMS, needs to be accessible. You need a clinical decision support system, which will then look at the laboratory values, look at the creatinine of a particular patient and say, oh, the creatinine is 2.0, whatever units. And therefore, if you're giving an nephrotoxic drug based on the SIMS software, it should be able to say, nahi, aap ye nahi de sakte hain. The pharmacist therefore should not be able to dispense the drug at all. That is the level of things that we're talking about. However, in our case, what happens? We have our the physicians who say, nahi, ye bahut zaruri hai, patient mar jayega, and so on and so forth. Of course, you need smart critical care. You need everything integrated. You need nurses no longer working as, transcriptionists, because we must realize that like we have our medical council, we also have the Nursing Council of India, and therefore important to remember that nurses are professionals. The more you use nurses to keep writing and documenting stuff, the more you're going to have bed sores, the lesser and lesser nursing care is going to be given, and that's going to create a problem for you at some stage. So all these devices that you see in this particular picture, whether it's the ventilator, whether it's the syringe pumps, whether it's the monitor itself, all of this is integrated real time with the monitor that you see at on the left hand side in the ICU at our hospitals, and that is what gives you real time alerts. So what is most important is that you don't lose time. So this is the system that we use. We have the ISA, which captures all data at point of care, analyzes it, gives actionable information, and most importantly, enables decision making. So I'll show you a few flowcharts, how it captures. This is how it captures data automatically. This is actually a patient, which is about 8 years old. So I guess it's okay to showcase. I should put a black box. It analyzes the data, like the total input, the total output, and many, many other things you can program. We, for example, have put all our infection prevention bundles on this as well. So that's something that we do here. And then it gives you actionable information based on whatever we do. For example, you can see on the left, we've got the WAP bundle, the UTI bundle, all of that is done on a daily basis. The best thing is that I think I learned this in 2002 when I joined this company, that we spoke about interfacing between laboratory equipments and the hospital information system. So then over time, we realized that you can not only do lab equipment, you can do everything else. So integration essentially is transferring the ones and zeros from this machine to that machine, rather than you getting into it and making it a game of Chinese whispers. That is something that creates problems, errors, legal cases, etc. Okay, so this particular software is able to integrate. This is therefore called a clinical decision support system, because it takes all the information from the primary information generator and gives it to the final person directly, who you don't have a phone call going this person so and so. The intensivist is able to see it on his iPad or his tablet or his phone. All of this simplifies clinician workflow, and you're able to customize it for various types of ICU. The same system is also used in the OT. This is a real-time picture from an OT. And remember, it never hurts to have a beautiful OT. It only contributes to the well-being of our doctors and nurses. So this is actually a picture from one of our patient care, where you're able to see the EtCO2, the InCO2, the oxygen, the SpO2. You're able to see medications that are being given, when it is given, and this is all documented real time. The next thing I'd like to come to and move on is smart nursing. I think digitization should not only touch patient care, but also touch the way our doctors and nurses function. So acuity-based staffing tools are available, which can be integrated with an acuity score, which you may give your patient. You may have a nursing care plan, which is also, I mean, it's a long thing which is there. So this, for example, shows the PEPD nursing care plan. Wockhardt has actually created its own nursing care plan, which we're very proud of. And I think that's a very good thing. Everybody should create a nursing care plan. And medication dispensing error systems, which you already spoke about. So coming down to Dr. Agarwal's question, I couldn't create a Parag Rindani model of digitization. I'm a very small person. But from my experience, this is what I've realized. The first thing that we always end up automating is that anything that affects the revenue cycle. Anything else that requires an output comes second. For example, lab reports, radiology reports. If we have to give it to somebody, we will actually put it in the system. So for many years, we used our computers as typing tools. The third possible thing that we've already come to, and that's the natural progression, is the clinical decision support system. What is now being used, and I think everybody is using it, for example, is using business intelligence to mine data for various reasons. It could be enhancement of business. It could be refills of pharmacy. It could be refills of tests. For example, if you have a diabetic patient, your business intelligence should be able to tell you at some stage through the digitization of records that this patient needs an HbA1c every 6 months. So 5 days prior to the 6-month period getting over from his previous HbA1c, the expectation is lab will send an automated SMS reminder. And somehow, for whatever reason, our doctors have beautiful handwriting and they love to write on paper. So clinical records will always remain a little bit last on the list. This is a Parag Rindani point of view. I beg pardon, but it is something that will always remain a little bit further away. Business intelligence will probably move up very quickly to third place. But this is my view on how to actually scale up if you don't have anything. You will have to start with those things that bring in the money. You'll have to start with those things where patients require an output. You will have to at some stage start depending on CDSS, because all of us know to err is human, and therefore you need these support systems, business intelligence and clinical records. With that, I thank you. And once again, thank you to CAHO, Dr. Agarwal, Lalu for the invitation, and thank you for your support. Over to you, Dr. Agarwal.
Thank you, Parag. As I told you, one of the very smart presentations from one of the most smart administrators. smart person. So I must say one thing, that you have very beautifully kind of explained both the HIMSS system and also in a way kind of a roadmap that people can take to start digitizing. I would say one thing, that yesterday there was a talk by Mr. R.S. Sharma, the chief of the National Health Authority and the Ayushman Bharat Digital Mission. So one thing which is going to come up and which will be probably a game changer for the hospitals who at least want to get onto this bandwagon. So they're talking about now systems which will be available to you at about almost like 500 rupees a month, and will be able to take you at least to stage 2 of the HIMSS, I think, without any problem. And there are many other innovators who are now coming in the field, especially of the remote monitoring, like of, the guys who made a ventilator in 48 days during COVID. So they are now coming with a smart ventilator, which is giving you a kind of all the kind of records that you are talking about in a much, I'm saying, much more economical way. So what I'm saying is that India, there is going to be an opportunity for people to adopt all this. I think the most important thing is your will and your determination that I have to start this journey. I think that is extremely important, because without that, there is no beginning.